welcome to NOAHE Rounds 9, Session 2. I'm Dr. Erin Kerwin, Managing Principal Economist at IHE, and I will be facilitating today's session. I'm also joined by my colleague, Dr. Leslie Sorrell, who is also a Managing Principal here at IHE, and Leslie will be moderating the Q&A. So we'll begin with a land acknowledgement. In the spirit of reconciliation and gratitude, the Institute of Health Economics acknowledges that what we call Alberta is the traditional and ancestral territory of Treaty 6, 7, and 8 regions, and the Métis settlements and the 6 regions of the Métis Nation of Alberta, whose histories, languages, and cultures continue to influence and enrich our community. So today our presenter is Dr. Kate Johnson. Dr. Johnson is an assistant professor with a joint appointment in the Faculty of Pharmaceutical Sciences and the Division of Respiratory Medicine at the University of British Columbia. She is a health economics and outcomes researcher who specializes in simulation modeling and comparative evaluation in respiratory disease. Her research uses real-world evidence to understand disease trajectory and patterns of care, followed by simulation modeling to evaluate healthcare interventions for reducing the burden of disease on patients and the healthcare system. She addresses health policy questions related to medication access, whole disease modeling of asthma and COPD with an emphasis on prevention and early intervention, the impacts of air pollution on the burden of respiratory disease, and the value of climate change mitigation strategies, as well as healthcare sustainability. So today's topic is the value of air cleaners for reducing the health impacts of climate change in British Columbia. So climate change is intensifying the frequency and severity of wildfires and therefore increasing the burden of respiratory disease on patients and the healthcare system. This talk will examine the value of portable HEPA filters for preventing asthma and related adverse events by reducing exposure to fine particulate matter. Dr. Johnson will discuss cost-effectiveness modeling to inform policy decisions on air cleaner rebate programs in British Columbia. The presentation will also highlight methodological considerations for incorporating environmental exposures into cost-effectiveness models, including strategies for managing uncertainty and involving patients in decision-making. This work highlights the important role of economic evaluation in identifying high-value climate change mitigation strategies. So before we begin, I'd like to go over some quick event housekeeping. First, participants are going to be muted throughout the webinar, so we cannot see or hear you, unfortunately. Second, to submit any questions during the webinar, please use the Q&A function. So the Q&A function is different than the chat function, so please look specifically for the Q&A function and please add your questions to that space. Finally, the Q&A answering your questions will be facilitated over the final 20 minutes of the webinar. So thank you again, everyone, for joining us, and I will now hand over to Kate.
Okay, thank you very much, Erin, and thank you for the invitation to present this work. I'm happy to be here today and talk about sort of a body of work in my group looking at the value of air cleaners and applying cost effectiveness analysis to evaluate it as a climate mitigation strategy. So I'd like to start off by just saying I have nothing to disclose, and I'm very thankful to live on the Musqueam, Squamish, and Tsleil-Waututh land, and as well as to my colleagues at the UBC Rest Lab, as well as Legacy for Airway Health and Center for Lung Health. So just a quick intro, this is our group. I lead a program in respiratory evaluation sciences along with my co-PI and colleague, Mohsen Sadat-Sfavi. And I just want to highlight 3 people who have contributed immensely to this work. Stephanie Harvard, who specializes in patient engagement. Spencer Lee, my former master's student, who led the second study that I'll present here. And Amina Dibi, who led the first study that I'll present here. So today I'm going to present 2 or 3 different studies. I hope it represents sort of an evolution of our attempts to answer this question, and so hopefully it'll all flow logically together. But the subject that I'll be presenting on is, as I said, the cost effectiveness of air cleaners for asthma, both asthma prevention and reducing asthma-related adverse events. I'm going to present first our first published cost effectiveness study, our second study, which is available as a preprint and represents sort of an evolution of the original model that we used, And then finally, I'm going to touch on some patient engagement work that we did around this question and how we're using the information that we got from that patient engagement into a second model and a second, or I should say a third cost effectiveness study around this issue. So we all know that wildfires are a big problem. These are some news stories that I took from last year, or this year, I should say, this summer, when it felt like most of northern BC was on fire. Here's an article from the New York Times. We know that wildfires are becoming more frequent and severe. And of course, we all know about the wildfires around LA that forcing evacuations. So we know that wildfires are a big problem. That's not news to anyone living in Western Canada, in which most summers we feel inundated with smoke, although it is a little bit newer to Eastern Canada. As you can see here, wildfire smoke from fires all over Central and Western Canada, and smoke drifting east. Interestingly, although 2025 was the second worst wildfire season in BC's history, most of the smoke, at least in southern BC, ended up going to you in Alberta and further east into Ontario. So in Vancouver, we didn't have too many smoky days. So as we know, future wildfires are likely to get worse. This is a study, a climate modeling study, showing trajectories in fine particulate matter, or PM2.5, which you'll hear me talk a lot about in this study, or in this talk. So PM2.5 is sort of a way that we measure wildfire smoke. It's comprised of lots of different particles, but it's our primary measure for measuring wildfire smoke concentration. So PM2.5 has decreased across Canada and the US, and this is a trend that started around in the 1980s in the US with the passing of the Clean Air Act, with reducing industrial emissions, things like scrubbers and smokestacks. So actually in the past 50 years, we've done a really good job of improving air pollution, particularly in urban areas. However, in the past 10 years, that trend has started to reverse due to increasing wildfires. And that's what you can see in these plots here from this paper. So this is in the US and different regions in the US, and showing across the US, but particularly in the Western regions, an increasing trend in wildfire smoke in the past 10 years due to increasing frequency and severity of wildfires. This is only projected to worsen because of climate change for a variety of reasons. One, increasing emission events, increasing the dryness, as well as also changing transmission dynamics as the atmosphere gets warmer, smoke is transmitted more. This paper here is showing 3 different emission scenarios. We call them representative concentration pathways. You'll hear me talk about them a little bit more. So 3 different climate change scenarios, essentially, and potential impact on wildfire smoke. This is the plot of BC. So just kind of a snapshot of what wildfire smoke has looked like in BC over the past 25 years. So in fact, now this graph we have data up until 2023, but if we include this past wildfire season, the 5 worst wildfire seasons on record have occurred in the past 10 years. So in particular, 2017, 2018, 2021, and 2023 were the 4 worst wildfire seasons on record, but this 2025 season was our second worst. So that's now made the top 5 all in the past decade. And you can see here a stable trend in non-wildfire smoke. So those blue bars represent non-wildfire smoke. So that's emissions from any other cause, be they industrial, agricultural, traffic. And that's been relatively stable over time. However, wildfires have been increasing, and particularly, of course, between May and September, which is when the wildfire season, which is when we typically measure them. So we know that PM2.5 in general, from wildfire smoke, as well as from other emission sources, has a variety of health effects. We know that it's linked to respiratory diseases, which is the focus of my research, in particularly airways diseases, chronic airways diseases, such as asthma and COPD. We also know that there are cardiovascular effects of wildfire smoke, and then it's related to several different types, many at this point, types of cancer, but in particular, lung cancer is often a primary focus. There's also emerging evidence for adverse effects on neurological outcomes and birth outcomes, such as preterm birth and low birth weight. In respiratory diseases, the mechanisms for harm are related to oxidative stress, inflammation, disruption of the immune system. And PM2.5, so the fine particles, can penetrate deep into the lungs, entering the bloodstream and affecting multiple organs. So in this research, I'm focused on asthma. We do have planned work in COPD and incorporating other additional outcomes such as cardiovascular disease and lung cancer. But for this particular talk, we're focused on the health effects of PM2.5 on asthma. Asthma is a big problem or is a very prevalent disease in BC. It's the third most common prevalent disease among all ages. Or the crude prevalence, I should say, in BC, affecting more than 650,000 British Columbians. And we know that there are lots of other types of strategies that the BC government has used to encourage, in this case, generally like power saving strategies. So we know that there's things in BC. We have rebates for smart thermostats, where at point of sale, a consumer can receive a rebate of up to $150 for a smart thermostat, which is energy saving. We have rebates for installing heat pumps and things like that. So we know that in BC, there is an environment in which technologies, including potentially air cleaners, now also air conditioners, have had rebates instituted. And so that's what we wanted to focus on in this study. We wanted to do a cost effectiveness analysis of government rebates for portable HEPA filter air cleaners. So many of you may have these in your home. They are small units, typically the size of sort of a computer monitor. Many of them have HEPA filters installed, which are sort of like screens, fine screens, in which air is pushed through the HEPA filter, and coarse material or coarse particulate matter is filtered out, and the air is cleaned, and the air circulates, and particulate matter is removed in that way. They are effective in removing fine particulate matter, less so in gaseous substances like nitrogen dioxide and that sort of thing, which is also a form of air pollution. So our question here was, what would the cost effectiveness of a BC government rebate program for portable HEPA filter air cleaners be for patients with prevalent asthma? So essentially asking if everyone with asthma in BC received a subsidy on a portable HEPA filter air cleaner, would that be a cost-effective strategy for reducing asthma-related adverse events? So we built a Markov model to answer this question. We initially answered this just from the healthcare payer perspective. We used a retrospective time horizon, which was driven by data availability of wildfire smoke, although I'll show you in the second study of how we expanded that to a prospective time horizon. So our time horizon was from 2018 to 2022. We used daily time cycles to reflect the episodic nature of wildfire smoke. We had health states for two main features of asthma, which is asthma symptom control, measured by as well-controlled, partly controlled, or uncontrolled asthma, and asthma exacerbations, which were defined by the extent of healthcare utilization. So what's called SES there means that a patient went and had an outpatient-related encounter that resulted in dispensing oral corticosteroids. They had an asthma-related ER visit or an asthma-related hospitalization. We conducted this analysis at the unit of health service delivery area. You'll see some maps later on, but there are 16 in BC. This was sort of driven by advice from our policy partners, who advised that this was the level at which healthcare is delivered, and therefore rebates, although ultimately may rest as a provincial policy, they were interested in looking at this question at a finer spatial scale, and so that's the one that we chose. And then we conducted a cost utility analysis using a willingness to pay threshold of $50,000 per quality. So our key model inputs, which I'll talk a little bit more about our wildfire smoke data in the next study, but we used a model that's developed in-house, now at Simon Fraser University, but it's called the CanAwesome model. It's a machine learning model that uses evidence from, or uses data from, a variety of sources, from satellite data, from LiDAR, lots of different things. And then it combines those evidence sources. It's then calibrated to remote monitoring stations. However, of course, those are spatially spotty, and so we need to combine evidence from many different sources. For this time frame, we had a 5-year time horizon from 2018 to 2022. We used evidence from the literature on the association between daily PM2.5 concentration and a variety of asthma outcomes. And I'll say, I don't show too much on the sensitivity analysis, so I'll say that these evidence sources in particular really drove our results. And in my last part of this presentation, I'll mention how we brought some of this evidence to patients and had some really good discussions that led to some changes in the types of evidence that we use to inform the health effects of PM2.5, as they were very influential on our results. So I haven't told you anything about how effective HEPA filter air cleaners are. We used data from an older study now. It was conducted in 2008, I believe, in northern BC. And there's two components that we look at when we consider exposure to outdoor air pollution. So the first one, and so keep in mind, this is outdoor air pollution. This is not accounting for emission sources within your home. So for example, if you're cooking with a gas stove or if you're smoking, this is not accounting for that type of air pollution. This is accounting for outdoor air pollution, which infiltrates through your home into the indoor environment. And that's represented by the infiltration efficiency without HEPA. So in this study in northern BC, depending on that housing stock, about 61% of PM2.5 from outdoor infiltrated indoor into the homes that were assessed. And then the study compared outdoor to indoor infiltration with a HEPA filter on, which reduced the PM2.5 infiltration to 19%, and therefore a filter effect of 31%. And I'll show you in the second study of how we updated that with some more recent evidence, although they found that in general, HEPA filters were more effective than that 31%. For this study, we chose a representative portable air cleaner, which you can see here, this blue air cleaner. And at the time, it had a price of around $150. It's a little bit more expensive now. And then we also chose to model a government discount on that retail price, as if the government would get sort of a bulk purchase discount. However, I'll mention that in the next study, that was sort of on the advice of our policymaker partners, but we ended up removing that as that was quite an influential assumption. And then finally, we do model, because this is looking at exposure to outdoor air pollution in the indoor environment, we also included the proportion of time spent at home of around 70%, and that was from a Canadian time use survey. So some major assumptions for the study. So one, we said that HEPA air filters were operated continuously. So for 5 years, the air cleaner was always on, although we did scenario analyses in which people only turned their air cleaners on during high air pollution events, which probably reflects real world use. I mentioned that rebate that we included in this original study. So HEPA filters do need to be replaced. The manufacturer recommendation is about every 9 months. So we modeled that. But because this base case analysis was from the healthcare payer perspective, we said that patients would cover both the cost of electricity, so we evaluated that, and the cost of filter replacement. Everyone in BC with asthma receives an air cleaner. And if there are 2 people with asthma in the same household, then there would be 2 air cleaners. The amount of filtration space that these air cleaners can cover varies by unit. In this one, it's about the space, I believe it's 150 square feet, so about the space of at least in Vancouver, an average bedroom. And then finally, we have this assumption about salbutamol dispensations, which is a reliever medication, like a puffer, was a proxy for worsened asthma control. And I've italicized that because in our patient engagement work, we ended up changing that as that was brought up as an issue. And importantly, we're only looking at the benefits of HEPA air filters for reducing exposure to outdoor PM2.5. HEPA air filters aren't selective to wildfire smoke. They also reduce exposure to allergens or indoor sources. And so we're not accounting for that in our evaluation of air cleaners. Here's some graphs of, or some plots of what PM2.5 looked like over our study time horizon. You can see some major peaks, particularly in the interior of the province and particularly in 2018 and 2021, in which, and just to give some sense of scale, in Kootenay boundary in 2018, a PM2.5 concentration of about 400 would be incredibly smoky. You would not be wanting to go outside. It would be difficult to see. There's probably ash on your car. So some really high exposure events throughout the time period, although very temporally variable, as you would expect. So here are our base case results. So this is again $150 rebate on HEPA filter air cleaners for everyone with asthma. The graph that you see, or the map that you see at the bottom, is our 16 health service delivery areas and the ICERs. HEPA filter air cleaners were only cost effective in one region of the province, which is Kootenay boundary at the southern interior of the province. However, over the model time horizon, HEPA filter air cleaners across BC would prevent close to 5,000 severe exacerbations, or outpatient exacerbations, I should say, 550 emergency department visits, and nearly 500 asthma hospitalizations. But the bottom line from this was that at that rebate level, only cost effective in one region of the province, which was particularly high exposure. We conducted some scenario analyses. So in the left there, you see if we lower the rebate to $100, it becomes cost effective in most of the province. In that second scenario, however, if we go back to the $150 rebate, but we only turn the air cleaner on when PM2.5 is greater than 25 micrograms per meter cubed, which is the BC threshold for high air pollution. I can't remember their exact wording. Then it no longer becomes cost effective. Although if we decrease the rebate to $30 and apply that same threshold for only turning on the air cleaner at high air pollution events, it becomes cost effective in some thresholds. And I should just note, in terms of, the fact that people do typically only turn their air cleaners on during high pollution events, I think it's important to note that there is no lower limit below which we do not observe negative health effects from air pollution. So although that may be how most people use their air cleaner, even low levels of air pollution have been shown to be associated with asthma-related adverse events. So there is clinical justification, at least, for always leaving your air cleaner on. And we have a nice web app that Amin developed that we'll probably update soon, but in which you can sort of explore the results of this cost effectiveness analysis with various costs and filtration effectiveness. So in conclusion, in this study, we found that although HEPA filter air cleaners can improve asthma symptom control, prevent exacerbations at the willingness to pay threshold of $50,000 for quality. Rebates of $150 were not cost effective. I see that this is an older slide. I phrased it as rebates of up to $100 for portable HEPA filter air cleaners were cost effective across most of BC. And that probably reflects the fact that when we presented these findings to policymakers and medical officers of health, they tended to regard this quite positively. And the message that they took from it was that, yes, providing air cleaners can be a high value use of resources, at least in certain high exposure regions. And we had a lot of good questions about, okay, how do we identify at-risk patient populations? So the major limitations of this, again, we are sort of disadvantaging air cleaners in that we're only considering their effects on asthma. And we know that there are other health effects of PM 2.5 that we're not accounting for. And then also, we only looked at short-term respiratory outcomes. So we didn't look at the effect of air pollution on development or progression of disease, although we do in the next study that I'm going to show. And then this was a retrospective time horizon. And at the risk of inundating you with results, which I probably already am, I'll just mention that we recently updated this because we got in data for 2023, which was the worst wildfire season in BC. Although very interestingly, although it was the worst wildfire season in BC, most of the smoke went east to Ontario, to eastern US. And so actually wasn't that high smoke exposure in BC. We extended the time horizon and we removed that 30% government discount because we think it's better without it, and did a $150 air cleaner rebate, updated filter effectiveness, various rebate levels. The results were relatively the same, still only cost effective at the $150 rebate in Kootenay boundary, but lower rebates become cost effective throughout the province. So the second cost effectiveness analysis that I'm going to present is one in which we took the same model structure with a few expanded health states, and we then wanted to look at air cleaners as a tool for asthma prevention. So looking at long-term health effects of PM 2.5 rather than just short-term. So this was work led by Spencer Lee, my master's student. So same model structure that we're looking at asthma in terms of symptom control and the occurrence of exacerbations. But we modeled a scenario in which everyone in BC is given an air cleaner, and we evaluate the impact on asthma prevention and downstream effects of asthma. So it becomes an even greater look for air cleaners in that we're giving everyone an air cleaner, and we're looking at, can it prevent asthma specifically, not other health-related effects. So again, we did a healthcare payer perspective. In this case, we expanded to include a societal. We used that $150 rebate. We've expanded the time horizon in this study. So in this case, we modeled a replacement air cleaner every 5 years. So the government would provide you another rebate to purchase a new cleaner every 5 years. And by the way, I'm not sure if I mentioned before that was based off of manufacturer recommendation for replacement time. We expanded to look at 2 different cohorts, and we adjusted parameters accordingly. So we looked at a childhood cohort in which everyone in the province, every child in the province would be provided an air cleaner starting from 5 years. We followed them up for a 25-year time horizon until 30, and then adults starting at 25 years. Similar exposure, so the same or similar exposure estimates. Time spent indoor, and then as I mentioned, we did update that HEPA filter air cleaner effectiveness to 48%. So once outdoor PM 2.5 has already infiltrated into your home, about half of that air pollution can be filtered out by a HEPA filter air cleaner. We did more work on the PM 2.5 concentration, expanding that historical time period, and then also developing some projections, which I'm going to talk about in the next few slides. Same unit of analysis, geographic unit of analysis of HSDA. So I have a few slides on how we developed these projections for PM 2.5, which I'll sort of say as an aside, we're not exposure scientists, we're health economists, and this wasn't necessarily something that we thought that we would have to do. However, projections at a fine enough projections of air pollution at a fine enough spatial scale to be used for this type of cost effectiveness modeling did not really exist. We're working on them now, or I partnered with exposure and scientists who are working on them now. But it was surprising to us initially that this work had not really already been done. And so we were sort of put in a position where, we had to do the best that we could, of course, with input from exposure scientist colleagues to develop these projections. So we had to use a variety of different models. CanAwesome, I've mentioned, that's our historical PM 2.5 model. We got projections of anthropogenic related air pollution emissions from Environment and Climate Change Canada. So they use these in government planning. Essentially, it is emissions from industrial activity along various trajectories. They model the chemical transport or the sort of transmission dynamics over time, but those don't include wildfire smoke. And so we had to get access to two more models used for short-term air pollution projections from Environment and Climate Change Canada in order to get at that wildfire smoke component. So this is what we did. So and sorry, I know there's a lot of acronyms here. I think that the most important thing to understand is that we had to use, and it's probably better illustrated by a figure in a few slides, but that we're combining multiple models here. We're having to use two different models in order to isolate wildfire PM 2.5 component. And if there's one thing that I can just sort of, make others appreciate is that when there's air pollution in the air, we don't actually know where it comes from. It doesn't come with a tag that says this is wildfire smoke. So the only way that we can kind of get at that information is by comparing models that are emissions. So they look at, they track the emission sources and the air pollution that moves throughout the atmosphere as a result of those emissions. And those are the two models called RAC-DPS. And that RAC-DPS firework feeds into, your sort of your everyday weather app that will give you an estimate of air pollution over the next 3 days, say. And so we got access to historical projections from that. And then I'll also add that we use this climate scaling factor, which I'm going to talk about in the next slide. Again, I think a figure in the next slide and 2 slides from now will illustrate this better. So we had this historical data that both allowed us to track total PM 2.5 and then using 2 more models, isolate the wildfire component of total PM 2.5. And we wanted to project that wildfire PM 2.5 component into the future. But we wanted to consider the fact that wildfires smoke is increasing over time. So we had to rely on these sort of lower resolution in terms of spatial scale, climate projection models that accounted for climate change emission scenarios, as well as changes in fire propensity, so vegetation. This one was using a high emissions pathway climate change scenario, and it projected in the Western US a 50% increase in wildfire PM 2.5 from 2001 to 2059. So we took that, we scaled that to our time period of interest from 2023 to 2036, and that informed our 11% high increase scenario. And then from there, we wanted to do, present other analyses in which we would assume a moderate increase in wildfire PM 2.5 or no increase in wildfire PM 2.5. So what this looks like is for this one HSDA. So here you can see all our models that we had to use to get at this question of what is air pollution going to look at in the future. In black, you can see our historical CanAwesome model. So that's the sort of our gold standard. You can see in blue our wildfire PM 2.5 component that we isolated using 2 different models, taking the difference between 2 different models. And then we took a 5-year average of wildfire PM 2.5 by month and HSD actually was a gridded area that was smaller than HSDA over that time period. And we applied our climate scaling factor, assuming essentially it works out to quite a small, less than 1% annual increase in wildfire PM 2.5 over our time period of interest. And then we added our anthropogenic emissions that we got from Environment Climate Change Canada. So a lot of work to get at one data point, or one data set, which is total PM 2.5 in the future. I'll just highlight here, many of the parameters were the same, but I'll just highlight here that we also included a concentration response function for the impact of PM 2.5 on incident asthma, both among children and adults. So these are results. As they mentioned, we had two cohorts, our child cohort from 5 to 30 and our adult cohort, which was followed from age 25 to 50 years. Again, you can see our 16 HSDAs, our incremental cost effectiveness of around $150,000 throughout the province, and then the number of exacerbations prevented over the time period. So these results showing that our $150 rebate, so if everyone in the province were given a $150 rebate for an air cleaner, and we tracked over time the impact on preventing asthma and the asthma-related adverse events, the cost effectiveness was close to $150,000, so not cost effective in any HSDA. When we decrease the rebate to $100, same scenario, we start to see some cost effectiveness in certain regions of the province. Again, those with typically high exposure and slight differences between children and adults. But now we're approaching an incremental cost effectiveness of $50,000. And then if we decrease the rebate further to $50, so now everyone in the province gets a $50 rebate for an air cleaner, the intervention becomes cost effective at a willingness to pay threshold of $50,000 in all throughout the province. So in conclusion, our higher rebate levels were not cost effective for asthma prevention. However, our lower rebate levels of $100 and particularly $50 became cost effective. And again, from our perspective, this was really quite a conservative study in terms of we were only looking at the impact of air cleaners on asthma, and at lower rebates, it was in effect, it became a cost-effective strategy for asthma prevention. I alluded to some future work. So as I said, policymakers that we work with are very interested in decreasing the spatial scale, or to look at susceptible groups, marginalized communities, elderly, and really targeted public health interventions around air cleaners. We do also, I just wrote a grant this fall with a colleague in engineering at University of Victoria, in which she's going to develop future PM 2.5 projections across climate change scenarios in a much more nuanced way than we were able to do here as health economists. And also we'll expand our model to look at all health outcomes. So we're going to include cardiovascular disease, different types of cancer, and that sort of thing. And we think that will be a sort of a truer estimate of the value of air cleaners. So I've thrown a lot at you, but I'll just wrap up here with a few more slides in which I want to talk a little bit about our patient engagement work, as it sort of was a thread throughout these studies and is feeding into our planned studies around the cost effectiveness of air cleaners. And so for this, we partnered with Stephanie Harvard, who I mentioned at the top, who has developed something called the Values in Modeling Framework. And we used these models and our question around air cleaners as a case study to implement that framework. So this was just accepted. I don't think it's, or it's perhaps in press at Pharmacoeconomics that describes this process. So the Values and Modeling Framework is a structured, theory-informed approach to involving transdisciplinary participators in health economics modeling. So it's not specific to patients, although in this case, our group included patients with asthma or caregivers of children with asthma. And it promotes explicit defensible decision-making by structuring deliberation on value-laden choices and their implications. So essentially what this process involves is characterizing modeling decisions into different types of decisions labeled as informant, pivotal, guideline, and opaque decisions. So informant decisions, meaning those that we're going to rely on expert opinion. I'll come back to the pivotal decisions, as those are the ones that I'm going to highlight here. Guideline decisions are those in which there are established conventions for doing things, for example, a discount rate, and opaque decisions in which we feel that we're not able to communicate, or we're not able to communicate the process to all different audience members. An example of that may be some of the methodological details of calibration strategies that we use. Focusing on pivotal decisions. So those are decisions in which we think a priori are going to be very influential on the results of the modeling. We then go to our next step, which is decision-making strategies. And we identify decisions as open or closed. You spend the bulk of your time on pivotal open decisions, which are democratized, meaning that we're going to bring these to the group and have deliberative, structured discussions around those pivotal modeling decisions. So I should just emphasize that this is a process for involving patients in the actual development of the model, not just the interpretation of the results. And then we have a commitment to transparent documentation of all decisions, regardless of whether they're open or closed. Okay, my second last slide, because I recognize I want to leave time for Q&A here, but I just want to highlight decisions that we brought to our patient group, who are all authors on that paper. We had 4 of them, and that we had in-depth discussions, really getting into the weeds of the data sources and the modeling and that sort of thing. So the first one was about these wildfire PM2.5 projections. As I said, we collaborated with exposure scientists. However, there's a ton of uncertainty in what the best way to project future air pollution is. In particular, our group was not very happy with the disagreement between the different sorts of models that we use, which are essentially a function of what the models are trying to do. And so we expanded sensitivity analyses. It's actually led us to using, we just got access to a different model with more results. And so that has sort of pushed us to paying more attention to that uncertainty and has changed our method that we'll implement in future studies as a result. As I said earlier, they did not feel that our proxy of reliever inhaled medications was a good approximation of asthma control. And so in future studies, we're changing our outcome, we're changing our source of literature to use a symptom-based or a patient questionnaire to measure asthma control. For PM2.5 on moderate exacerbations, they wanted us to verify what types of visits were included. And then in terms of similarly PM2.5 on severe exacerbations, they emphasized the importance of looking at temporal heterogeneity or essentially a lag between when a patient with asthma has an experiences a high air pollution event and when the consequences or an exacerbation are likely to occur. And then also finally, when we were looking at using reports from the literature on meta-analyses on the impact of air pollution on asthma incidence. There was a lot of discussion around the different data sources, and we decided to expand some sensitivity analysis. So it was quite a time-consuming process. I could get more into it, but it really led to meaningful changes in our strategy for the actual modeling of this work. And I'll just end, this is my final slide, in saying that the much of the decisions that came out of our patient engagement, as well as much of our future air pollution projections, are now going into a third model, which is a whole disease model that we've developed in our group as a platform for evaluating a variety of asthma prevention strategies, so not just air pollution. And that this is an active area of research in our group, and the next stage is to essentially add air pollution to this model and enable comparisons of asthma prevention strategies. So I'll stop there, and thank you very much for your attention, and I'm very happy to take questions.
Okay, thank you again, Dr. Johnson. This was so interesting, like extremely fascinating work. I really like the tie into the values and modeling framework at the end as well. Just really cool way to circle back to the initial assumptions. So we're now going to invite attendees to use the Q&A function in the software menu. So please add your questions there. But in the meantime, I've got a few questions of my own that we can start with while we're waiting for everyone to get into the Q&A. So my first question, and I may have missed this while you were presenting, but I was just wondering if you could talk a little bit more about how the rebates were implemented in the model. Like, are the rebates assumed to be uptake? Like, are you assuming universal uptake? Is there any sort of gradient with that, especially geographically?
Sorry, and can you just repeat that last part? Am I assuming that they?
So
can you just?
was everyone going ahead and purchasing a HEPA air filter with the rebate, or was there some degree of differential uptake, especially like regionally?
Yeah, so we did not look at uptake. We assumed that everyone purchased a HEPA air cleaner, received the benefit of a HEPA air cleaner, but the purchase cost was reduced by the level of the rebate. So the only way in which we incorporated adherence was in that first study where we looked at people only turning on the air cleaner during high pollution events. But essentially everyone in these studies, in both of these studies that I presented, had the air cleaner at their disposal.
Okay, all right, that's really helpful too. And then I also was curious about, could you unpack the result about why it was more cost effective for adults in the second study? I feel like my priors would have been that it would be more cost effective for children's prevention, but so I'm kind of interested to hear more.
Yeah, it's a good question. I don't know if we have a good answer. Maybe because I have my slides up anyways, I'll just flip back to that one. This one for the base case. Yeah, so I mean, we had some difference in the parameters. There is a stronger effect for air pollution or for PM 2.5 and asthma incidence in children than adults. So we might have expected the opposite. But I mean, largely the results were relatively similar between the two cohorts. In terms of there being, a slight higher value in adults. I'm not really sure. In some cases, some of the parameters we did use different sources of indirect costs and that sort of thing that could lead to some smaller discrepancy. However, I will just say that in terms of the health impacts of air pollution, it is quite well established that particularly for asthma, it tends to be worse in kids. So I think that's a line of questioning and investigation that bears further work on our part.
Okay, no, that's really interesting as well. And then I see a couple of questions filtering in, but while I can selfishly keep the mic for just a moment, I was wondering if you could talk about how you handled uncertainty with respect to the projections from the different models. Like obviously, it's very complex to combine these different estimates and get to your forecast. But were you able to incorporate any uncertainty with those forecasts in the simulation modeling?
Yeah, so that's a great question. So essentially our approach to uncertainty was to evaluate different scenarios. So a scenario in which there was no increase in wildfires versus moderate versus high increase informed by this other study. The question of uncertainty around the actual, there's many different layers of uncertainty when we're thinking about air pollution projections. We certainly have like high heterogeneity in air pollution, both spatially and temporally, and that's been quite an interesting problem to apply that into our cost effectiveness models. So in this case, we essentially assumed like a point estimate of air pollution averaged in this study by month for the future period, as well as by HSDA. So there's variability there, but in terms of uncertainty of the actual like point estimates of exposure, we didn't include that, and it's actually not provided to us. for both the future emissions projections, those provided by our Environment Climate Change Canada, and our historical projections, they only give us a point estimate of PM 2.5. I'm told that there could be some sort of uncertainty interval or confidence interval around their point estimate. I'm not entirely sure of the reasons why they don't include it, but that does seem to be kind of convention in the field. And I will just finally note that I think probably uncertainty in the actual point estimates of PM 2.5 concentration is sort of drowned out by uncertainty in the health effects. And that those are probably the much more influential factors when we're ultimately looking at the cost effectiveness of the intervention.
Okay, yeah, no, thanks for that. That makes a lot of sense. I always think it's really interesting to see combining parameters from other disciplines and kind of how we can think about that in PSA. So it's always cool to hear people are doing that. So go to the Q&A. So go ahead.
I was just going to say, it made us uncomfortable having to pretend to be exposure scientists. And although we were partnering with great people, it was kind of interesting that our work from the health economics angle has now sort of driven additional exposure modeling work. Whereas at least among my group, people are quite reluctant to do projections of air pollution due to the high uncertainty. However, they're obviously of extreme policy relevance, and it's important to tackle.
Yeah, no, super cool. And it's great that it's opening up avenues of research beyond your own program as well. So we have a question from Dr. Jiabi Wen. She says, thank you, Dr. Johnson. I have a question. In the second study, you evaluated a universal HEPA filter rebate for the entire BC population as an asthma prevention strategy. From an implementation standpoint, it seems more likely that individuals with pre-symptoms or who self-identify as being at risk would be the ones who would actually choose to purchase a filter, which could effectively increase the rebate level among those most likely to benefit. Is this something you've considered or a direction that you see for future work?
Yeah, that's a great point, and I think that sort of builds on, Erin, your first question about uptake. So in the second study, we had sort of envisioned this one as similar to our smart thermostat rebate in BC, which is equivalent to, when you currently, if I go to Best Buy and buy a smart thermostat, I at point of sale get $150 off certain select models. We had envisioned a similar mechanism for these air cleaners, so it would be at point of sale, but that certainly does lead to your question about uptake, who is more likely to purchase an air cleaner, and it definitely stands to reason that it would be people with comorbidities, those more that make them more vulnerable to air pollution exposure, and that among those individuals, we would likely see higher value of air cleaners. We don't have any plans at the moment to look into that, but I think that's a really good point that we could think about more. And I'll just also emphasize that it does echo what we've heard from our policymakers, that they're really interested in targeted public health interventions to at-risk groups. They see it a little bit more in terms of distribution, like who can we purchase air cleaners for and distribute them to. But I think it's also an interesting angle if we can looking at uptake and how patient characteristics influence both uptake and then their exposure to PM 2.5.
Okay, thank you. Our next question is from Dr. Benjamin Walker, who says this was a really great talk. And he says, I was wondering if you considered varying the assumed effectiveness of the HEPA filters at removing PM 2.5, wondering if it could be cost effective if HEPA technology were to improve in the coming years and become better at filtering HEPA 2.5, PM 2.5, excuse me. And then he also goes on to say, I was also wondering if the rebate was per person or per household. Would it be potentially cost effective if per household instead?
Yeah, so I'll answer that second question first. So it is per person. It's a per person rebate. I think it could be more cost effective per household. However, most portable HEPA air filters do not have the filtration footprint that covers an entire household. Like your average sort of, as I said, kind of like computer monitor sized air cleaner is probably only good for an area. It'll say based off of the air cleaner, but the area of around a moderately sized room. And so while it may increase the cost effectiveness, we would also want to account for the fact that the filtration would be less effective. In terms of the how influential the filter effect is on our results. I believe I have somewhere in the slides, we definitely did both a DSA and a PSA on that. And maybe this is for the first study, and I maybe have slides, although this is just for Kootenai boundary. This is for my master's students, so I'm not exactly sure what the arrows are. And there's a lot here. But I think we do have, yes, effectiveness of HEPA filter air cleaner in reducing. It's just one bar above that second arrow. It doesn't look that influential, at least in this DSA. But I mean, we could stand to reason that it would affect the cost effectiveness. And I'll just again emphasize based off of this slide that it's really those health impacts. So what we call the concentration response function for PM 2.5 exposure and the influence on asthma outcomes, particularly incidence, and then also asthma control, that were driving the results of the model. And that was another reason that we wanted to bring those studies in particular to our patient deliberation group, to make sure that we are, to the best of our ability, using the best evidence.
Okay, thank you. Next, we have a question from Nathan Locke, who says, "Thank you for sharing. This is really interesting work." And he's wondering about how the exacerbation treatment affects work during short periods of very high pollution. So were there any challenges in applying / interpreting the treatment effects for exacerbations during periods of very high pollution?
Yes, there were. It's very, so that sort of speaks to how we're planning to do this in the future, which is around the impact of PM 2.5 on exacerbations. So typically when we go into the epidemiological literature, these are modeled as lagged effects. So from a given, reference air pollution day. So if there's 1 day of high air pollution, some people will immediately have an asthma exacerbation. In some cases, it will take people 3 or 4. Usually in the studies that I've seen, they've modeled up to 4 days of a lag effect on asthma exacerbations. So there's sort of high temporal variability in how air pollution affects people with asthma that's influenced by a variety of factors, many of them like self-management, different disease characteristics. So in this case, we did not model that. So in the first study in which we had a daily cycle on a high pollution or PM 2.5 was associated with an increased risk of asthma exacerbation on that day. In subsequent work in that whole disease model I mentioned, we should be able to incorporate that temporal heterogeneity in the impact of PM 2.5 on exacerbations. I hope that answers your question.
Yeah, I think that should probably cover it. We have one more question about the rebates, but I feel like it's very similar to the questions you've already answered. But it is fascinating to see how many of us are just really focusing in on that rebate program design thing. I guess my last question before we have to wrap up here would be just about the openness of, it seems like your decision makers that you were working to inform were quite interested in potentially having a regional policy or regional distribution. Is that true? Because in my work in Alberta, I've found that usually there's a preference for sort of universal programs and not geographically targeted programs.
Yeah, I think that's true. And I think it largely depended who you talked to. So we were mostly talking to medical health officers in different regions throughout the province, a little bit centered around Vancouver Coastal Health, but also in the northern interior. And from their perspective, they were thinking about it as if we have some money in a public health fund, that they would purchase the air cleaner and they would distribute at that, at the household level to groups, to vulnerable or at-risk groups. So that's how they were thinking about it and why they wanted us to go finer geographically in terms of should we really give these to. However, we did speak with a couple of people at the Ministry of Health level in which they were thinking about it as a province-wide policy, and ultimately a rebate would be a province-wide policy. So we do also report BC overall results. So we sort of were getting pulled in 2 directions depending on who we would talk to.
Okay, that is interesting. Not actually, maybe unsurprising. Okay, thank you. We're gonna wrap up now. So I want to thank you once again for your presentation, and thanks to everyone online for attending. Our next seminar will be presented by Dr. Rebecca Marsh and is scheduled for January 21st, 2026. So please visit noah.ca to register for any of the upcoming sessions, and please subscribe to our mailing list to get updates on NOAA events and opportunities. Once again, thank you, Dr. Johnson.
Thanks for having me.